Hey, and I got to meet some of you yesterday, so I have several friendly faces in the audience, which I appreciate. So the title of my talk today is Adolescent Obesity, Psychosocial Consequences and Adverse Outcomes. And what I'll be presenting is work I've done to date in my postdoc. So my postdoc is in the Division of Adolescent Medicine at Boston Children's. And the postdoc is in obesity and eating disorders and looking at the intersection of the two. So I'll go through some of my research and finish with future directions, what I will be doing, sort of what has informed my current research and what my next steps are. I will start with a quote by Kelly Ronell from Duke. He's someone who just speaks in eloquent sentences, and I think he really simply and perfectly states what the public health problem that faces many of our adolescents today. It is difficult to envision an environment more effective than ours for producing nearly universal body dissatisfaction, preoccupation with eating and weight, clinical cases of eating disorders, and obesity. And I have to put up a slide with something about the obesity epidemic, because I don't know how to give a talk without showing the slide. But I think also we think about this a lot in public health. We think about the obesity epidemic and what's happened from the 70s to today. This data is specific to adolescents. At last count, obesity in adolescents exceeded, it was just over 18%. If you expand this data to include adolescents who are either overweight or obese, that number exceeds 30%. And if you look only in racial and ethnic minority youth, that number approaches 45%. And we all know that obesity is a multifactorial, multi-system disease. Really no organ system or body system is spared consequences of obesity in childhood and adolescence and into adulthood. The focus of my research and my talk today will be narrowing in on this little box of psychosocial consequences of obesity. There are many. Listed here we have eating disorders, poor self-esteem, body image disorder, social isolation and stigmatization, and depression. And the intersection of obesity and eating disorders, or at least disordered eating behavior, is not sort of a new concept, it's not new to the literature. It's something that's been studied more in females than males, and most of the data I'll talk about today relate to females, but I'll sort of comment on sort of the state of the literature, the state of the evidence in boys. And we know that the intersection in these behaviors starts early. Young overweight girls are at risk for dietary restraint and weight concerns. This is data that comes out of Leanne Birch's group. I did an analysis of it was an ongoing RCT trial looking at disordered eating behaviors in both young boys and girls who were overweight or obese. They enrolled in the trial because they were overweight or obese. Eating in the absence of hunger is common, and a behavior that actually had not been studied before in young people, food sneaking, hiding, and hoarding. We saw that more than 30% of the kids enrolled in the trial. The intersection between disordered eating and obesity has also been well described among adolescents. This is some data that comes from Diane Newman-Steiner's group, the Project E cohort. And in this paper, she looked at the intersection between overweight or obesity, extreme weight control behaviors, which includes using diet pills or laxatives to control weight, smoking to control weight, or use of self-induced vomiting to control weight, and binge eating. I'll talk more than you want to know about binge eating today, but briefly here, binge eating is a behavior that's characterized sort of with two parts. The first is eating an objectively large amount of food, more than someone else would eat in sort of a similar circumstance, and experiencing a loss of control during that eating episode. So the pink circle, these 361 young people, these are just the females, are all overweight or obese. And you'll notice a lot of overlap with binge eating and extreme weight control behavior, such that about 40% of the overweight or obese girls in the cohort engage in either binge eating, extreme weight control behaviors, or both. In this paper, they report data on the boys in the cohort, and similarly you see an intersection. It's not as great as with the girls. You see about 20% of the overweight and obese boys engaging in binge eating and extreme weight control behaviors. What's important to note, though, is the extreme weight control behaviors that adolescent girls tend to use are probably different than extreme weight control behaviors that boys use, which may involve more likely hyperexercise or use of performance-enhancing supplements, which weren't included in this study. So if we included those, it's possible that you can see even more overlap than they report. So moving on to another psychosocial consequence of eating disorders, body dissatisfaction. And body dissatisfaction is thought to arise primarily from social cultural pressures to be thin and physical deviation from the current thin ideal for women in Western culture. So thin ideal is the image we see see on billboards what sort of a supermodel looks like and what people think is the right way to look. One would hypothesize that the greater the degree of deviation from the current thin ideal, the greater the ensuing body dissatisfaction. So I'm going to put this slide back up, sort of highlighting that our population has gotten heavier. And the thin ideal sort of moves around a little bit. There's some that would argue that it has gotten thinner over time. It seems like it sort of ebbs and flows a bit, but it certainly has not gotten substantially heavier. But our population has gotten substantially heavier, which would suggest that body dissatisfaction is probably a growing problem, and that more and more people are falling farther and farther away from what is the thin ideal. And we do know that body dissatisfaction and weight are highly correlated. Rates of body dissatisfaction increase with body mass index among adolescent girls, and body dissatisfaction is particularly high among girls who are overweight or obese. So this is a picture from a paper I worked on with a colleague of mine at Boston Children's, Gerald Calzo. He actually did his developmental psych training here at Michigan, so I've got some nice Michigan ties. And we looked at using the Growing Up Today study, which is a study I'm going to talk about quite a bit, and I'll give you some more detail, but essentially it's a cohort of adolescents. And we looked at the association between BMI percentile, because these are youth, so we couldn't use straight BMI, and body dissatisfaction. So along the x-axis we have greater adiposity, and the y-axis we have greater body dissatisfaction. And these different color lines actually just represent increasing age, with the lowest line representing the folks in the cohort who are ages 9 to 10, the red 11 to 12, 13, 14, 15, 16, 17, and 18. So the take-home message here is pretty simple and actually probably pretty obvious. Restart now? Absolutely not. They're not really giving me another option.
Yeah. What's 10 minutes?
Yeah, it's not giving me the choice. What's that? Oh. Okay. We'll see what happens. Okay. So the take-home message here, which is not really a surprising one, is that you see greater body dissatisfaction with higher adiposity and higher age. And in the lower ages, at age 9 to 10, that lower black line, you see pretty sort of even body dissatisfaction until you get to the 50th percentile, which is sort of a median or average body weight. But in the lower ages, you see more of a linear relationship that essentially only the very, very thin kids are satisfied with their body, and body dissatisfaction continues to get worse with increasing BMI. In this paper, we also report data on boys, and we see actually a different relationship, an interesting one, where we see a U-shaped relationship with greater body satisfaction in the thin boys and in the overweight and obese boys. The two gray lines that you see on the picture here represent the 85th and 95th percentiles. You can see at the line for overweight and the line for obesity, you see quite high levels of body dissatisfaction in those adolescents. So more simply stated, we use this image to assess weight perception in gut. So I did not draw this, but I think it sort of illustrates who the kids in the sample are and how they feel about their bodies. So to answer the question, who is the most satisfied? It's only the really thin girls. The average weighted girls are not feeling particularly satisfied. Then who is the most dissatisfied? It's the overweight and obese girls in the sample who are the most dissatisfied. And I think it's important to propose what seems to be a pretty important and provocative question. Should girls who are overweight or obese be satisfied with their bodies? And I ask this question, a lot of my research interest stems from my clinical work, and I always tell a story about a doctor who I worked with who worked at obesity treatment, and she was very senior and offered lots of wisdom about how she interacted with patients. And she said, if I see an overweight or obese girl who wants to lose weight, I tell her whenever she thinks she wants to eat a snack to go to her room, take off her clothes and look in the mirror and decide if she really wants to eat that food. And I remember hearing this as a really junior, I was a dietitian, I hadn't even gone back to my doctor at that point. I remember thinking, that's wrong to tell someone to do this, that people should be motivated by self-hatred or body dissatisfaction. But there's this competing idea of, if people are not dissatisfied, are they going to make changes to change their body weight if their body weight is in fact putting them at risk of a whole host of adverse health consequences. And there is some discussion about arguments actually for body dissatisfaction in the literature. There is an idea that a moderate amount of body dissatisfaction may serve as a motivator for healthy lifestyle change. Again, if you don't hate your body, why are you going to do something about it? Overweight adolescent girls who are not dissatisfied with their bodies have been called a risk group, that they are people who are more likely sort of suffer these consequences if they're not hating their bodies. And I think an important clinical question and a public health question is it appropriate to promote body satisfaction while also trying to encourage weight loss and prevent obesity? On the flip side, there are several arguments for body satisfaction. So for liking one's body, higher body satisfaction is associated with lower use of unhealthy weight control behaviors and more physical activity. Higher body satisfaction protects against increased BMI in overweight adolescent girls. This was also done using the Project EAT cohort. And the association between obesity and depressive mood, which is well described, appears to be accounted for by variations in body dissatisfaction not related to obesity itself. So the association between body satisfaction and the onset of binge eating has not been investigated among overweight and obese adolescents, and I was interested in looking at the interplay between some of these psychosocial consequences and asked the question, is body satisfaction associated with yearly BMI change and instant binge eating disorder in a cohort of overweight and obese adolescent girls living through the United States? So the cohort I used to answer this question is called the Growing Up Today study. We refer to it lovingly as GUTS. If we could go back in time, we probably would have named it something different. So participants in the Growing Up Today study are children of women who are in the nurse's health study. In order to be in the nurse's health study, you need to be a nurse. And women who are participating in the study were, in 1996, asked if we could send letters to their children inviting them to enroll in what was this, the Growing Up Today study. And if they said yes, we sent the kids letters, and they agreed to participate. In decent numbers, we have over 9,000 girls, almost 8,000 boys, and in 1996, when the cohort was formed, participants were 9 to 15 years of age. And we send them questionnaires every year, every 2 years, so this sample is actually around 30. We have another cohort that was enrolled about 10 years later, and so we have another sort of young cohort that's aging through adolescence. But the data I'll present today all comes from the Growing Up Today 1 study. For the present analysis, I included girls in the 1996 to 2007 waves of GUTS who were either overweight or obese in 1996. I'm looking at body dissatisfaction only among overweight and obese girls. I think everyone will agree body satisfaction is a good thing if you have a healthy body weight, but the sort of unanswered question is how this association looks among girls who are overweight and obese. So we assess body satisfaction in the GUTS cohort with a question, in the past year, how happy have you been with the way your body looks? They're given response options that range from not at all to totally. And I dichotomized the response options to create a category which I would describe as at least somewhat satisfied with the way your body looks. I think an adolescent girl to be totally satisfied, that might be sort of a hard concept, but these folks are at least a little bit satisfied with the way their body looked. And we assess body satisfaction in every survey year up until 2001. So we looked at 2 different outcomes. First, I wanted to look at BMI change. There was one other study that had looked at body satisfaction predicting weight change, but that's a sample that's only in Minnesota, so not a very geographically diverse sample. So I sought to replicate their findings. And the new research question was whether or not body satisfaction was associated with a behavior, or the binge eating behavior. And I defined frequent binge eating to be greater than or equal to weekly binge eating without purging. And this frequency cutoff matches the new DSM-5 criteria for binge eating disorder. We can't officially say these folks have binge eating disorder because there are other diagnostic diagnostic criteria we're not able to get at through our questionnaire, but we know that they're binge eating at a frequency that mirrors folks who have diagnosable binge eating disorder. To assess binge eating, again, because it's a sort of 2-part behavior, it's a 2-part question. We first ask, during the past year, how often have you eaten so much food in a short period of time that you'd be embarrassed if others saw you? And anyone who endorses this, we call this overeating, anyone who endorses overeating is given a follow-up question. Did you feel out of control, like you couldn't stop even if you wanted to? And to rule out cases of, or to separate out cases of bulimia nervosa, we also ask the purging question. During the past year, how often did you make yourself throw up or take laxatives to lose weight or to keep from gaining weight? To look at the associations, I used just generalized estimating equations to account for clustering among families. We have several sibling sets within the Growing Up Today study. I do all my analysis in SAS using Prochat. Girls who were binge eating at least cases were removed. The analysis is a lagged analysis, such that I'm looking at the prospective associations of body dissatisfaction at one time point and association with weight change or incident binge eating at the next time point. And I ran multivariable models with fully adjusted models accounting for age, baseline BMI, television viewing, and maternal overweight and obesity. It is a luxury we have with the Growing Up Today studies. We also know a whole lot about these kids' moms because they're participating in the Nurses' Health study, so we can include their obesity status. Just to give you a sense of sort of binge eating behavior in guts, and it's important to acknowledge that guts is not a national representative cohort. There are children of women who are nurses, and so what they look like in terms of socioeconomic status does not reflect what would be a nationally representative cohort. The cohort is mostly white, with about 93% of the participants are white, but again, it's a snapshot that is geographically, at least a geographically diverse sample. In 1996, when the kids are about 12 years old, mean age ranging from 9 to 15, 27 of the 1,559 kids were binge eating at least weekly, so 1.7% prevalence at baseline. Over the next 10 years of follow-up, an additional 136 participants reported weekly binge eating in at least one survey wave, so that amounts to 9.5% of the sample. So I show here the results of body satisfaction association with weight change over time. And the results of the fully adjusted model, you'll see here, this is a beta coefficient and 95% confidence interval. What's important to note is that we see a negative and significant association, such that the girls who liked their bodies, those that were at least somewhat satisfied with their bodies, gained significantly less weight over time from one survey year to the next. We see a similar association here presenting an odds ratio because we're looking at incident binge eating disorder. And in the fully adjusted models, we have what I would argue is a pretty impressive odds ratio of 0.39, showing that body satisfaction is actually quite protective against the onset of binge eating disorder. Again, with the odds ratio of 0.39, highly significant. I also looked, I said that I dichotomized that variable into at least somewhat satisfied versus not satisfied. I was also interested to look, is there maybe sort of a dose response of body satisfaction in the association between satisfaction with one's body and the onset of binge eating disorder? And in fact, we do see what seems like a dose response. And in that category of a lot / totally satisfied with one's body, we see very low levels of incident binge eating disorder. In fact, I had to lump a lot and totally together because there wasn't a single incident case of binge eating disorder in folks who said they were totally satisfied with their bodies. So it does seem that not just a little body satisfaction, but a lot of body satisfaction is protective against the onset of binge eating disorder or frequent binge eating. To summarize that study, compares their more dissatisfied peers. Overweight and obese adolescent girls who were satisfied with their bodies gained relatively less weight and were less likely to start binge eating frequently. I think there are important public health implications of that finding. In particular, body satisfaction may be a salient target for both obesity and eating disorder prevention. I want to sort of kind of take a step back and think about binge eating and weight or weight outcomes. I think it's important to acknowledge that the relationship between binge eating and weight potentially is bidirectional. So we know that overweight and obese girls are more likely cross-sectionally to report more binge eating. This is work, again, coming out of the Growing Up Today study. This work done by my mentor, Allison Field. In the reverse, adolescent girls with binge eating disorder are more likely to become overweight and obese. And this is, again, work that I've done with Allison Field. But what's important to think about is that binge eating is common, and we know that it's associated with obesity, but this is sort of a public health problem in and of itself. It is the most common disordered eating behavior. I show here data from the National Comorbidity Follow-Up Study that looks at prevalence of eating disorders in the U.S. population. This is a nationally representative sample. And you'll see actually BED compared to BN, which is bulimia nervosa, and AN, which is anorexia nervosa. BED is actually the most common eating disorder. It certainly has very little press if that's something that you count in terms of public health importance, but it is the most common eating disorder. We know that eating disorders tend to be more prevalent in females than males, but still a third of the cases, or a quarter of the cases, I'm sorry, of binge eating disorder do occur in males. And I think there's really important assumptions that we make about eating disorders that actually aren't actually true. We see more binge eating disorder in Hispanic and non-Hispanic Black youth compared to white youth, and actually the disparities between eating disorders that involve binge eating and are sort of kind of reversed the assumptions that we have about eating disorders. I think minority youth is a really important risk group for binge eating and any eating disorder. So greater than just diagnosable cases of binge eating disorder, it is a prevalent behavior, just binge eating. This is data, again, from the Growing Up to Date study, where I look at frequent binge eating in orange, which is weekly binge eating, and infrequent binge eating, so monthly but not weekly, in blue. And infrequent binge eating at this frequency criteria is actually included also in the DSM under a category that's being referred to as other specified feeding and eating disorders, OSFED. I don't know if people read the DSM-5, but there's lots of funny acronyms in the new DSM. So this is sort of considered an important public health problem, an important mental health problem. But we see really low binge eating in the young individuals in our cohort, age 9, almost none. And this really increases steadily throughout adolescence and peaks at about 7% in older adolescents, age 19 through 20, and then stays pretty stable into young adulthood. So like I said, it is common, but it's also important to know that many individuals who binge eat are actually not overweight, and the risk of binge eating may extend beyond weight-related consequences. And I was interested in sort of exploring why else should we care about binge eating if we can figure out how to solve obesity in other ways. Binge eating really a problem? And so I sought to answer the question, is binge eating prospectively associated with adverse health behaviors or outcomes during adolescence? So other risk behaviors that we're worrying about in our adolescence, is there overlap, or is there potentially kind of a chain of events that happens during adolescence related to risk behaviors? Some of the outcomes I was interested in looking at were frequent binge drinking, marijuana use, other drug use. These are all exposures we care about for a variety of reasons, and high depressive symptoms, another important psychosocial correlate of obesity. So we assess adverse outcomes in various ways in various surveys. Frequent binge drinking in girls is defined as drinking more than 4 drinks in one sitting, and the frequency has to be greater than 6 episodes in the past year to qualify as frequent binge drinking. We assess that on those survey years. Marijuana use we define as any past year use of marijuana. We ask that about every other year. Not in the first years because the kids in sample were young, and we didn't start thinking about their drug use until a little bit later. Other drug use changed from year to year depending on sort of what people were using. We added and took away questions to sort of capture the most common drugs of use during adolescence. And we assessed depressive symptoms to capture the top decile of depressive symptoms in our sample. The reason we did that, which is the delight of working in a cohort, is that measures change and you have to figure out what to do about it. And so we had measured depressive symptoms using the McKnight Risk Factor Survey, which is a 6-item validated scale. McKnight Risk Factor essentially assesses risk for eating disorders, but they have a depression measure. And we switched to the SESD short depression scale in 07. And so high depressive symptoms in any year is represented by being in that top decile. For this analysis, similarly, I measured log odds of the hazard rates of the adverse outcomes using, again, GEE accounting for clustering within siblings. We censored prevalent cases from the analysis. Again, this was a prospective analysis, and all models controlled for age and BMI, and the various we added to the models differed because they're very different behaviors that we are assessing. So the reference group in all the analyses are folks that do no overeating. So folks that endorsed or said no with that first question of eating so much in a short period of time you'd be embarrassed if others saw you. And we're comparing those who binge eat to folks who endorse no overeating. As expected, binge eating predicts the onset of overweight or obesity. So individuals who are normal weighted who binge eat are likely, again, to develop overweight or obesity. We saw no association with frequent binge drinking. It's probably important to note that frequent binge drinking is really common in her cohort, but so we saw it's associated with everything and nothing, I guess, the way to think about it. Among girls who were binge eating, greater onset of marijuana drug use, and associations prospectively with high depressive symptoms. I'm going to switch gears for a second to talk about purging. I spent most of my time today talking about binge eating, but I think it is just one of many disordered eating behaviors. And I looked at similar associations that I just reported as part of a project I'm working with a doctoral student in the UK who's interested in looking at purging and how it differs in different communities that have a large cohort. So we're comparing rates with the UK, with Finland, and the US with these different cohorts. So looking at rates and also associations with adverse outcomes or with risk behaviors. And these associations, their report here are cross-sectional, they're not prospective, but we see a really similar trend with strong associations. Interestingly here with frequent binge drinking, it's probably interesting to think about what are the traits of someone who engages in purging versus binge eating. They're both related to impulsivity, but very different behaviors. And here we see a strong association with binge drinking, smoking in the past year, marijuana use, other drug use, and high depressive symptoms. To summarize this line of work, disordered eating behaviors increase risk of outcomes related to and unrelated to weight, which I think brings binge eating into a bigger makes a case for binge eating being a bigger public health problem than maybe it is currently considered. It is prospectively associated with the onset of marijuana use, starting to use other drugs, and worsening depressive symptoms. And purging is cross-sectionally associated with frequent binge drinking, smoking, marijuana, and other drug use, and high depressive symptoms. So I want to switch gears for a second and talk about future directions of where, so it's actually July 9th, so as of 8 days ago, from July 1 we started the academic year, I'm no longer a postdoc. So I've been doing mostly research with my mentor, Allison Field, but I've had the fortune to also sort of get my next steps in line and have worked on several other cohorts and the development of another registry to begin to answer some of my independent interests. The first being exploring the interplay between psychosocial and physical correlates of obesity. And this pertains to both the prevention of obesity and the prevention of obesity consequences. More specifically, whether psychosocial factors predict obesogenic behaviors is understudied. So the first example here, body dissatisfaction, with the arrow going to physical activity or inactivity to weight gain. So physical inactivity is an important target in both prevention and treatment of excess, or prevention of obesity, prevention of excess weight gain, and in obesity treatment. We do know that folks who are less satisfied with their bodies are less likely to be physically active, but it's unclear what the role is of body dissatisfaction in that pathway and whether or not body dissatisfaction should be the important research target or the public health message, or physical activity is really the right message. Similarly, we don't know whether psychosocial factors may actually explain associations between what we know are risk factors and obesity or excess weight gain. Short sleep duration, I think we're hearing a lot about sleep and its association with excess weight gain and obesity, and there are a lot of theories why metabolically that short sleep may increase risk of obesity or excess weight gain. But I started to look at what might be some behavioral mediators of this association, including binge eating and emotional eating. Folks who are sleeping less are more likely to engage in binge eating, more likely to engage in emotional eating, and whether or not this is sort of explaining the associations. I think there are a lot of physical explanations, but psychosocial explanations should be considered as well. Both of these research questions I will continue to explore using the Learning Today study. It is a great fortune to have access to longitudinal data on such a large sample. And the kids in this cohort have provide us lots of data on their eating behaviors and how they feel about their bodies, on their mood, on their physical activity. And these are just two of several questions I intend to answer. Also, I'm interested in the prevention of obesity consequences and the role of psychosocial correlates, and particularly binge eating. I always say there's more than one way to eat too many calories. And I think when we look at consequences of obesity, we don't account for those differences. And if we imagine that binge eating is a special way or a unique way to get in too many calories, is there additional risk that binge eating confers that would increase risk of adverse health outcomes that we typically associate with obesity? So for example, binge eating is often the foods that folks binge eat on are typically high in glycemic index, high in high fructose corn syrup, high in trans fat, high in sodium. So is gaining weight with these foods different? Might that change your cardiovascular disease risk if you are gaining weight by eating too many calories in a way that's sort of spread out over the course of the day with sort of a wider variety of foods, or are binge eating episodes adding additional risk? Further, binge eating, by definition, is eating a large quantity of food in one sitting. It's actually really hard to quantify how much folks are eating during binge eating episodes because what is a binge for one person can be very different from what's a binge for another person. But in some lab-based studies, we assume that sort of an average binge size or mean binge size among adolescents is 1,000-ish calories. So the question is, what implication does that have on insulin response, on body composition? Again, is that changing your risk profile for an outcome such as diabetes or any other cardiovascular disease risk factors? So to look at these questions, I've had the good fortune to sort of marry my clinical life with my research life. And I haven't talked a lot about my clinical work, but I co-direct an obesity program that's housed within the Division of Adolescent Medicine. And at Boston Children's, we have 4 obesity clinics. That's a story for another day. We have 4 obesity clinics. And we have just a lot of treatment-seeking obese youth that come to our hospital. And we have the 4 clinics, the directors of the 4 clinics, we have partnered to enroll all of our willing patients into a research registry and a cohort. And the goal of the cohort, which is called the pool cohort, is twofold. So one is to really be able to phenotype these kids. Because I direct the adolescent clinic, we have the best enrollment rate because adolescents are desperate for research incentives. So we actually have most of our patients in the cohort, and we are measuring body composition. We have the body, we're doing resting energy expenditure. We have biologic samples. We have urine. We have more psychological assessments, which is certainly my doing. But they come in and they are there for a whole day of assessment. And so using data from this registry, I'll be able to look at those folks who endorse binging or endorse emotional eating, sort of what their sort of risk profile looks like and whether there are differences based on this sort of psychosocial presentation. Also, as a part of the pool cohort, so we're creating this registry, but we're also tracking treatment outcomes. And I think we don't know a lot about psychosocial predictors of treatment success and failure. And some come to mind are body dissatisfaction. Based on the research I talked about a minute ago, it would be worthwhile to consider the role of body dissatisfaction or an intervention related to body dissatisfaction in obesity treatment. Again, we can think of body satisfaction, binge eating, self-esteem, self-efficacy, coping skills, all these psychosocial characteristics. We don't know how that predicts treatment success and failure. And I think research and looking at who within our cohort is successful could ask some questions about why, how we can maybe optimize the obesity treatment we're providing in our clinic. And also in a time of limited resources, how might we tailor who we refer? If we can't refer everyone, let's refer people who are most likely to be most successful. And my final future direction, my interest obviously, is in binge eating. I think there is a bit of research related to binge eating in public health, and I think the evidence base for the detection and prevention of binge eating disorder needs to be expanded. We have collected in regarding today's study data on treatment-seeking behaviors among folks with any eating disorder, and we know that individuals with binge eating disorders are very unlikely to seek treatment for their eating disorders. They may show up in an obesity program, but they're actually not seeking treatment for what is a psychological illness that needs to be treated. So there is a high need for better detection. I think doing screening for binge eating in an obesity program is a start, but it doesn't allow us to capture those folks who have binge eating disorder who are not yet overweight or obese. And those, I think, are the people who we want to find, because those we can sort of prevent some of the adverse outcomes that are associated with the onset of binge eating. I think more importantly, we also need to prevent cases of binge eating. I think there's a lot of need for ongoing research in identifying who is at risk and why. I find it really surprising and interesting that racial and ethnic minority youth are those that are most afflicted with binge eating disorder. I've just started looking at some data collected through the Boston Youth Survey, which is a really nice diverse sample of youth from the Boston area, but we have a nice mix of and looking at whether or not there are racial ethnic differences that may predict the onset of binge eating or the onset of greater obesity in those risk groups. I think the final goal I have is something I'm doing right here, right now. I think eating disorders are not something that we talk a lot, or we talk about in schools of public health very often. I think eating disorders are preventable and should be part of the conversation in public health, particularly in institutions where obesity prevention is a priority. I've had the good fortune of working on a training initiative called the Strategic Training Initiative for the Prevention of Eating Disorders. And our mission is to bring eating disorder prevention to the public health community. One of the activities of our group is to write cases that can be taught in schools of public health and integrate messages related to eating disorder prevention with other public health lessons. And for folks who are interested in case-based teaching, which is something I'm learning about and am very excited about, we have our first case, which is free on our website, that can be printed off and taught in schools of public health. I would be delighted to come here and teach our case, but I think public health, the binge eating has a place in public health as it relates to weight, as it relates to other adolescent risk behaviors. And with that, I'm going to put up my thank you slide and open up questions. Answer this up a lot. Yeah, we have plenty of time for questions. I'm going to go through some of those slides.
So if your body physical activity risk, how do you know which way to go? I mean, is it overweight, is that satisfaction? Where do you, how do you get the factors aligned?
Right, so I don't think we know right now. I think structural behavior modeling techniques we can employ to look at developmental trajectories of development. I think the GUTS cohort, we are well suited to look at that association. What we end up having to do is exclude everything that's prevalent at baseline, which doesn't necessarily make the associations very generalizable, but at least we can draw the data points of this happened first and this happened second. Unfortunately, we started at age 9, and I think there are many much earlier predictors of things related to body satisfaction and physical inactivity that we're not capturing, so I think we need younger cohorts to fully understand that association.
But you do have that GUTS cohort, because you have those different age groups.
Yeah.
Discern out of that, which is happening. So people that are on a trajectory for weight that you can see in the earlier ages are those more likely to be dissatisfied later on. One way, it seems like you didn't analyze it.
Yes, and I haven't analyzed it the other way, and I can. Yes.
One of your last slides when you were talking about purging.
Yes. Yep.
With your model, you included marital status of the mother. And
Yes.
I just wanted to know why you did that and what your relationship is.
I rolled my eyes because that was not my decision. So this is a doctoral student. Woo! Okay. So this was a doctoral student, and I am not her advisor, who's working from the UK. And what I bring to the table is my data and my analytic skills to sort of compare to her cohort. So it is difficult, and I think really a challenge of folks who work in large cohorts is that if we want to marry cohorts and data collected from other places, is that there are often not common measures, and there's very few things that we know, or that we know that we measure in a similar way. That happens to be one thing that we measure across all 3 cohorts. And so she elected to include that in the model. That changes the associations not at all, but it was sort of a decision she made a priority. It is associated with. Let me think about this. It's associated with risk behaviors. It's not associated with purging, but we included it in there. It doesn't change the result. So an interesting question, and one that I can't explain that much because it wasn't much. Yeah.
Near the end of the talk, you mentioned emotional eating, stress eating, and so on. And in light of the story you told about the person who said, well, I just tell my patients to look at themselves in the mirror. I study mass media effects on the body, which is disordered eating and obesity, and I do subscribe to Mark Steiner's view of the spectrum of weight disorder. But I see that you've run into the same sort of frustration where you have to make a case that body dissatisfaction actually isn't a productive thing with overweight kids. And that seems to be linked to this pervasive, and I don't know why people have gotten around this pervasive view that eating is a rational choice behavior. Right. So I'm wondering what your view of that is in the current just sort of the clinical side of the field, how you're managing that, how you try to get people to get around that?
Yeah, it's funny because you know how you ask you come up with a research question and you do the analysis, you sort of do this because you don't know what your findings are going to be. It was one of those where I saw my results and I was so relieved because it's exactly the story I hoped it would be, and if the story had been different I would have reported it anyway, but it was really surprising that it worked the way that I imagined, and I thought others would be equally excited, equally like-minded about this idea that positive body image and related concepts like positive or good self-esteem may be universally beneficial. And I brought this analysis to our research team. We have to present with a research plan with preliminary data. And I don't think I've ever had an analysis question more than this. And there are a lot of clinician researchers in the room. They said, yeah, but this doesn't really make sense. And it surprised me. I couldn't imagine that there would be that type of response. And for that reason, I'm delighted I asked the question. I'm delighted I was able to get this published in International Journal of Obesity, because whenever people confront me with that sort of argument, I say, you should see my article in International Journal of Obesity in 2013. I think it's important for our work to say the evidence is not there, that body hatred is important. But I think that the issue you bring up extends beyond body satisfaction, and particularly in light of the mass media. I think obesity campaigns that are stigmatizing and shaming overweight kids and adolescents particularly, or overweight folks in general, and sort of using this sort of disgust with one's body as an approach. I think that there are media campaigns that are still continuing to do that, and I think messages like this have really important clinical implications, but also implications for public health messaging. We certainly don't want to stigmatize the folks that we are trying to reach, and we don't want to exacerbate existing stereotypes. We certainly don't want to do more harm than good. And if this type of messaging related to weight and bodies is increasing risk of eating disorders, maybe we could help one problem. It doesn't look like we would help obesity with these messages, but we're certainly increasing another problem.
Do you see racial differences in body dysfunction in terms of who that works for? So does that work for a certain population and does not work for others?
That's an awesome question. The question is related to racial ethnic differences in body satisfaction. There is a whole psychology literature on body satisfaction and differences by racial ethnic group, and it's a really complicated one. So in guts, I'm not able to look at that. Unfortunately, you sort of get the great data you get, and my great data happens to be a sample that it has very little diversity. In adult women, there was a time where we thought that racial ethnic minority women were protected from the body dissatisfaction related to sort of the thin ideal, which is sort of typically a thin white ideal that we see in media. And then there was an idea that, or some data suggests that as we're seeing more diversity in media images, we're seeing more body dissatisfaction. So we want more diversity in media images, and sort of the negative consequence is body dissatisfaction. It is totally understudied in adolescents and young people as to sort of what becomes acceptable body types and where that curve might change and what BMI or maybe see an increase in body dissatisfaction. So I think that's a ripe area of development. And I mean, they're easy questions to assess. We're pretty good at assessing body image, and we're really good at assessing BMI. So I think it's something that we can easily look at.
You're certainly right that not everybody who has a eating disorder is obese or overweight. And I know this because I lived in a sorority house when I was in college, and there were a lot of eating disorders, and they were not at all overweight. But given that you're focusing in on obesity, I guess, I'm not really sure what the intervention would be different for somebody who does have binge eating or any kind of disorder that doesn't necessarily lead to obesity or does. How would that change?
So also another area where the answer to that question is we don't really know. So binge eating disorder treatment in adolescents is virtually unexplored. In adults, we have evidence-based treatment approaches to binge eating disorder, and those are psychological treatments. They're not behavior treatments. So we know that both CBT and DBT are effective in treatment of binge eating disorder. What is strange and an important area of inquiry is how folks can improve their binge eating but not lose weight. In all of these trials, we see people remission of binge eating behaviors, but their weight stabilized. And what probably needs is redistribution of calories, which I think is probably metabolically healthier and certainly psychologically more healthy, but we're actually not seeing people lose weight when they binge eat less. So I'm actually working with Deb Schaefer out in Stanford, somewhere on the West Coast. So she's done some work in young adults, looking at a DBT curriculum and a binge eating disorder. We're looking to adapt it for adolescents to see what effect it has on binge eating outcomes and whether or not it affects weight. What we think is that we'll have to marry behavioral intervention and a psychological intervention, and what's unknown is whether one should come first and one should come second, or if they can be done in tandem. So do we worry about the binge eating? Once that's in check, then we can worry about weight, or do we get people losing weight because that will maybe increase treatment buy-in, and then we can sort of work on the eating pathology later. So I think it's an unknown
Could
area.
that be the bodies, the change in the body satisfaction?
Yes.
Okay,
Yeah.
I guess I was.
Right, so we're hoping for a change in body satisfaction, a change in BMI, and a change in binge eating behavior. Yeah.
So I was really struck with the high ratio related to eating disorder and purging to onset of depression, incident depressive symptoms, I guess.
Depressive, yeah.
Could you say a tiny bit more about your thoughts about the biologic and the psychosocial mechanisms and or pathways? Is that direct, indirect, cyclical,
Right.
somewhere?
Yeah, so that's definitely something I'm hoping to look at using pooled data. So I think that both binging and purging are physically taxing, are psychologically taxing, and sort of what is the stress response that gets, or what is the stress exposure that leads someone to binge eat or to purge, and then what is the biological stress response to a binging episode, to a purging episode. Whether or not that, I think we would need to do some more momentary sampling to actually understand what happens pre-binge, what happens post-binge, or pre-purge or post-purge. But I think we have a lot of really formative work to do in terms of who are the people who are binging and purging, what is their stress level. This is when I talked about mostly today. There's also a lot of shared risk factors, but there's also empirical evidence that you can do one thing and help both, sort of simply said. And I think sort of the classic the classic study that was done that looks at that came out of Karen's work with Steve Gormaker and Julie Asia, the Planet Health Intervention, which is a school-based intervention that was done in public schools in Massachusetts. And what's interesting is that it was designed with no eating disorder thought in mind. It was meant to sort of promote health behaviors. It was not obesity treatment, it was obesity prevention. So it was offered to everyone in the school, so some folks were certainly overweight and obese. But it focused on just general health messages related to reduction in TV viewing, fruits and vegetables, physical activities, sort of the messages that we sort of all know and love. And among girls in intervention schools, they saw much less weight gain, significantly less weight gain from 6th to 7th grade. And Bryn Austin, who is a colleague of ours, looked at purging behaviors, and they saw a reduction in lower odds of starting to purge in the intervention schools. And what's so interesting is that there was no mention of eating disorders, there was no mention of body satisfaction. It was sort of a kind of a pro-health message, and sort of focusing on kind of strength and resiliency, and focusing on those messages inadvertently or sort of serendipitously decreased purging behaviors. And this is something that's been replicated in other trials using the same curriculum. And I think one of the take-home messages for me in reading those studies, the obesity and the purging behavior study, is that there may be other things that we are doing in obesity that could and should decrease eating disorder risk, but we just don't measure it. I think there is it's just a separation of the eating disorder research community and the obesity research community, and I think obesity folks should measure consequences related to disordered eating of their interventions and vice versa, because it would be wonderful if there were more examples of this. I think to think about cost effectiveness of public health interventions, if we are targeting more than one outcome, it becomes immediately more cost effective. And if you think about the other behavioral and adverse health outcomes related to eating disorder behaviors like substance abuse and binge drinking and depressive symptoms, it becomes infinitely more cost effective. So I think it was a novel analysis that really sort of opened my eyes about how to be doing research in any one of the areas.
So I think we have time for one more
So Dan Keating, who's here at the School of Psychology, has been, he just started about 2 years ago looking at a brain imaging study, and what they're finding, so they use the Moving to Opportunity cohort as well as a couple other cohorts that use, like you were saying, a pretty basic, pro-health intervention, and what they're seeming to find with some preliminary evidence is that the changes in these kids' brains, I think it's between 4th and 7th grade, it's very similar to what you would see in kids who are going through more resource-intense therapy, such as EMDR, some very intense, like 3 times a week CBT.
Right.
So I just think that's very interesting, and so I'm very curious to see how that goes further. That he's seeing that the self-regulation, measured in many different ways, just seems to improve with basic mentorship and with basic health messages at each stage. So,
Age 4 to 7 or grades 4 to 7?
grades 4 to 7 is one of the cohorts, and then basically he's looking at taking advantage of the plasticity of the brain through adolescence, because you can't always grab kids at a young age.
Right.